All right. Now, for those of you that have been with us from the very beginning of this CHoSEN journey, you know that in 2017, we started CHoSEN with a focus on birth hospitalization. And while we have moved beyond the birth hospitalization, I still want to emphasize the birth hospitalization as a really important opportunity to engage with nearly every infant, birthing person, and family. Now, certainly we now know, and we've known for a long time, that the health of mothers and babies doesn't start and end at the hospital. We know that social determinants of health, broader factors that exist in communities really influence perinatal health more than anything else. And yet, the birth hospital is where we can really interact with nearly all birthing people and infants because 98.6% of all births happen in a hospital. And we know that for some birthing people, they may not necessarily choose or have access to prenatal care, or they may be late into prenatal care. Some certainly may deliver at home, which is a very small percentage. I know for those of you in Colorado, you think this number is much higher than national estimates. It is not. But we know that the birth hospital, as limited as that time is an opportunity where we can interact with nearly every birthing person, every new mother, infant, and family. And so I still think of it as a really golden opportunity for us to engage with compassion and empathy so that if there are individuals who have not yet started their recovery journey, there's an opportunity to engage. And for those that have started their recovery journey, an opportunity to continue to support as they transition from hospital to home. So with that, as we do in all of our CHoSEN forums, I'll give a very brief data update. And data, presentation, collection, etc., not possible without Blair Weichel, our excellent quality analyst. Is Blair in the room? I'm looking around. Blair? Oh, she usually hides because she hates it when I share her picture and her awesome work. All right, so this is going to be a whirlwind. So shown here, what I'll show you, data that goes up till Q3 of this year. And so this report represents 2,814 infants who are prenatally substance exposed from 2017 to 2025. That's nearly 3,000 maternal infant dyads that you all have taken care of and that you all have then entered data into our system for. That's incredible. And so when we talk about individual level influence, absolutely, but the work that we've been doing for many years clearly shows population level impact in improving the health of our mothers and babies. We collect limited information on sociodemographics. Shown here are prevalence estimates for maternal ethnicity as well as race. Far on the right is the number of dyads that are captured in the data system. You can see there's some variability over time. And you can see that the majority of our maternal infant dyads are non-Hispanic, yet nearly a third are of Hispanic ethnicity. We have 70% that are white, and then a smattering of other racial ethnic groups. Now, while Colorado is not an extremely racially diverse group in terms of birthing population, you can certainly see that the ethnic proportions show us that there is a rising Hispanic population, and the data that I'll show you will demonstrate some of the disparities that we're starting to see. And so with respect to the racial, the Black, white, American Indian, Alaska Native populations, these numbers are relatively small. And while there is not quote unquote statistically significant differences, I would say that the N of 1 or individual families receiving disparate care is in fact a preventable harm. So as we think about data in aggregate and data locally, I would say think about that N of 1, even if your monthly data shows that there may not necessarily be disparities over time. Shown here are mothers receiving medication for opioid use disorder. Now, our definition for this is Not awesome, but it's what we have. So it's any documentation of use of methadone, buprenorphine, Suboxone. Now, what we don't know is if there is ongoing engagement in treatment. What we don't know is if there is potential illicit use of other substances along with MOUD. That being said, you can see here that perhaps we saw a slight increase from the baseline mean of 54% to about 60% back in 2019. Since then, there's been no change. And so while we see some variability in data points, when we really look at the mean or the average over time, we're not seeing a significant improvement. So this tells me that our birthing people with substance use disorder are not necessarily more likely to be engaged in treatment by the time we meet them during birth hospitalization. Here we have the length of stay for all infants who are prenatally substance exposed who are greater than or equal to 35 weeks and whose length of stay is not affected by other diagnoses. And so you can see here back in 2018 when CHoSEN first started, this is where we see the first very dramatic decline in length of stay from about 2 weeks down to a week. And this was work that was driven around Eat, Sleep, Console, around family integration at the bedside. How do we optimize non-farm support for these infants? And then we had a greater decline back in 2024, such that the average length of stay for these infants is down to about 5 days. Now, I mentioned the need to understand whether or not we are reducing, sustaining, or increasing disparities over time. So we look at our data in a stratified way by Hispanic ethnicity. So on top, you can see length of stay for IPSEs born to Hispanic mothers, and then on the bottom, length of stay born to non-Hispanic mothers. And what I'll show you is that while they both experienced declines, we know that for the Hispanic population, that decline took a longer period of time to achieve. And then more recently, their new average length of stay is close to 8 days compared to for non-Hispanic mothers, which are 5 days. Now, what we haven't yet done as a collaborative is really do a deeper dive on why this is happening. And I think this is a really important area that we need to think about in the year to come. Why is there this difference that we're seeing by Hispanic ethnicity? And I think many of us can hypothesize, is it a language barrier? Is it racism, stigma, bias? Is it the other social determinants of health that influence parents' ability to be at the bedside? If these infants are in fact in the NICU. So many things that we have to think about. We know that the need for pharmacologic therapy really drives the infant length of stay. And so shown here is the percentage of infants prenatally opioid exposed only that receive pharm therapy. Again, dramatic declines when CHoSEN first started, where we had where we had over 50% of infants that received methadone or morphine for opioid withdrawal, and then came down to about 24% very quickly. Overall, we've sustained that percentage, such that about a quarter of our opioid exposed infants are receiving some sort of pharm therapy. I'm going to zip along here because I'm already late. Okay. We also look at eligibility for mother's own milk. Now, Colorado overall has really high breastfeeding rates. I think we're actually the highest in the country. And so here we see the top percentage of IPSEs eligible for mother's own milk. So eligibility for CHoSEN is defined as those that are discharged to biologic parents. And so you can see here that breastfeeding eligibility has increased from 70% up to 90%, 88% to be exact. And then on the bottom, we see the percentage of IPSEs who actually received their mother's own milk. So among those who are eligible who actually receive their milk. And so we see it was about 81%, and then recently we're at 72%. So I do think there's still opportunity here to improve provision of mother's own milk for these infants. That being said, I would say these numbers are really high compared to other states. This 72%, I would say, is what most states want for their general birthing population of provision of mother's own milk. Okay. This is where we need a lot of work. So here we have the percentage of IPSEs who received antenatal consultations. So before this birthing person delivers, was there some conversation or anticipatory guidance around what to expect for their infant and for themselves during birth hospitalization and thereafter? The numbers are real low. We started off at 4.5% and most recently are 8.8%. Now, we absolutely acknowledge that part of this is a data capture issue, right? So this is electronic medical record data that we're inputting into our data system. And so it could be that conversations have happened in the prenatal period, but was not captured in the EMR. But to be honest with you, in reality, I don't think these percentages, if we really captured all of those, would be that much higher than what I'm reporting here. And so, as I highlighted, while our work focuses on the birth hospitalization, we have so much work to do in the prenatal period and then in the post-discharge period. Here we see a little bit of improvement. Here we see the percentage of IPSEs who received early intervention referrals. We know here in Colorado that prenatal substance exposure does not automatically qualify an infant to receive EI services, although it should, but anyone can make a referral, and we consider these infants to be high risk and to have another set of eyes go into the home to evaluate these infants and offer support to the families we think should be part of that discharge plan. And so we have seen incremental increases. We went from a baseline of 20% and then most recently close to 60% of our IPSEs have an EI referral in place prior to hospital discharge. Now saw a decline here in the earlier years, a few years ago, but we've seen a dramatic improvement. And I know I'm way over time already, but I just want to highlight this because I don't think we're necessarily having an EI focused talk. You know what led to this improvement is that local hospital teams did a process map. They wondered who actually makes these EI referrals. Now, even in our big university hospital system, when I asked who makes the EI referrals, it was like silence. It was crickets because we didn't know. I mean, the person who did it knew, but nobody else knew. And so just identifying the workflow for how infants are, first of all, who makes the phone call to the person who has to physically fill out the application and make the referral. And then what does that conversation with families and with discharging providers look like? So once we understood the workflow and identified the appropriate person, things got better. So it's not rocket science. It's really just talking to each other to understand the workflow at our hospitals that makes a really big difference. Okay. This is another area, post-discharge, percentage of IPSEs who received handoff to a primary care provider. Again, I know some of this is data capture. For instance, at Denver Health, it's a closed system. Most PCPs can just look into their Epic and get a full comprehensive discharge summary. Therefore, phone calls may not necessarily be happening. That being said, if we say these are high-risk infants for which not just medical transfer of information, but all the social things should also be communicated to the outpatient providers, I think this percentage should certainly be higher. And so clearly this trend is going in the wrong direction. And so we have a lot of work to do. And I know it seems like for those of you that have come to these forums, the antenatal consult and that handoff to PCP is an area that always feels like it's lacking. I do think that we have invested a lot of time, energy, and resources into making it better. And you'll get a sense of that during our workshops. What are some of the innovative opportunities that we think about transitions of care and improving these transitions? The last thing I'll highlight is that we've been doing this work since 2017, and because of all the work that you have done, the high quality of care that we deliver to our families affected by substance use, we are leading the science and the innovation. And so we are disseminating our work broadly. And I'll give you a few examples. And again, I'm going to share some publications with you, but know that it's not about the authors that you're going to see listed. All the work is based on what you have done at your local sites and the data that you have shared and the innovation that you've developed. So Eat, Sleep, Console, we're probably one of the first states to have adopted it at the state level and share data. Pretty early back in 2017 to 2019. Neonatal toxicology. How do we think about equitable toxicology for the maternal infant dyad? How do we harmonize policies for both the birthing person and the infant during the birth hospitalization? Pregnancy and lactation. This is always a hot topic. Who's quote unquote allowed to breastfeed? Who's quote unquote allowed to provide their own milk to their infants? And how do we think about having policies that are really equitable, inclusive, and reduce stigma and bias? Plans of safe care, you'll learn a lot about that today. There still isn't an awesome definition, but Shannon, I'm so glad you're here. It's really in working together that we think about plans of safe care and how we think at the state level for having consistent guidelines, and then state initiatives to improve care for our infants and families. And really, it's really with the partnership with our Perinatal Quality Collaborative that we think about disseminating this work within our own state and then nationally. All right, so I am 12 minutes behind already, but I thank you for listening. We're going to transition to our first workshop, which would have started 2 minutes ago. So please find your first workshop and know that that will go until about 10:15, probably 10:20 is just fine before you transition into your second one.